Let's talk about arrhythmias. We're going to just talk about like a general breakdown of action potentials, how the conduction system moves through the heart, get into different supraventricular tachycardias, ventricular tachycardias, etc. And especially a big thing is reentry circuits and just how they work. Um, so tachycardia versus bradycardia. Tachy too fast, brady too slow. Specifically, less than 60 beats or more than 100 beats. So if you have a fast rhythm or a slow rhythm, that's not necessarily bad, right? This could be a normal sinus rhythm. Sinus just means that it's systematic, it's regular. If you're going on a run, you're going to have sinus tachycardia. If you're sleeping, you're going to have sinus bradycardia. If you're an athlete, you just in general walking around have a lower resting heart rate. So that'll also be a sinus bradycardia. But it could be irregular, and that's typically what we're worried about. So signs of extreme tachycardia and extreme bradycardia, again, we're going to mostly be concerning ourselves with irregular arrhythmias here. So you're going to decrease your cardiac output. Now, if you have bradycardia, well, you're not, cardiac output is heart rate times stroke volume. If your heart rate's too slow, then you're going to have a low cardiac output. If it's too fast, we said, well, if it's so fast, you might actually have a problem filling during diastole. So you also have a low stroke volume. You might have an abnormal pulse, particularly slow, or a racing heartbeat if it's a tachycardia. Syncope, which is fainting and dizziness because there's not enough oxygen getting in your brain. General fatigue because there's not enough oxygen getting anywhere in your body. Chest pain, which is due to coronary ischemia. And then cardiac arrest, also known as sudden cardiac death, which is where you die within 1 hour of the onset of symptoms. Things like VFib, VTAC, or asystole that might develop. Reasons this might happen. So if it's sinus, it's just going to be the catecholamines or the vagus nerve, the sympathetic or the parasympathetic. Now, for the irregular tachycardias and bradycardias, the pathological arrhythmias, which we're concerned with, could be that an MI or ischemia or coronary artery disease generates scar tissue somewhere, and this increases the likelihood of reentry circuits, which is an island of non-conduction in the center of conducting tissue, which we'll see. Hypoxia. So we mentioned earlier, hypoxia leads to cell depolarization. And this is because you can't fuel the sodium-potassium pump, which pumps potassium in and sodium out and helps maintain this gradient. And if you're not fully depolarized, if you're not fully hyperpolarized after an action potential, this doesn't fully activate the sodium channel. So you have a slower conduction velocity and a slower funny current for the pacemaker cells and the myocytes, respectively. Hyperkalemia causes the exact same effects. Again, it causes a depolarization, which causes all of the same stuff. In addition to the fact that we might have a more intense drop in our phase 3, which leads to a shorter refractory period. Remember that Purkinje fibers are particularly vulnerable to changes in electrolyte concentrations in particular drugs. So this will help us explain how we can develop ventricular tachycardias. Hypokalemia has the opposite effect, hyperpolarization. It's a faster phase 4. The diastolic depolarization, which leads to tachycardia. Antiarrhythmic drugs can also lead to irregular tachycardias and bradycardias. So note that for all of this to occur, for the most part, it's really just changes in conduction velocity, repolarization, diastolic depolarization, and the generation of these scar tissue non-conducting islands that mostly lead to arrhythmias through reentry circuits. And again, here we have a good picture of what hyperkalemia looks like. Notice that it has this lower resting potential for our cardiac myocyte. It has a slower phase 0. The sodium pumps or the sodium channels are not as activated as they should be. The slower conduction velocity means that it's going to take longer to pass the message from one cell to the next cell. And when you've got billions of cells to get through, this means that it's going to take a couple extra fractions of a second to conduct a full heartbeat. In addition, we have a shorter refractory period and a much more intense drop in our phase 3 repolarization. Bradycardia, we mentioned, this is just the vagus nerve. Maybe you're sleeping, maybe you're an athlete and you're resting. And again, this is just decreasing our phase 4 slope. A conduction block is You could have a conduction at the SA node, you could have it at the AV node, you could have it at the bundle of His. These are typically caused by beta blockers, whether it's type 2 or calcium blockers, which are type 4, or just ischemic damage due to the AV or the bundle of His. This can also just slow conduction, moving from the atria to the ventricles. Less concerned with bradycardia, more concerned with tachycardia. A couple different ways this can develop. Abnormal automaticity. For the most part, this is caused by catecholamines, which we mentioned can speed up the phase 4 diastolic depolarization. Triggered activity is new. So this is where an especially long phase 2 or phase 3, a long QT period, can actually somehow, there's like an issue with the ion channels, it can initiate another action potential, sort of in the middle of an action potential. If it's towards the end of phase 2 or phase 3, it's early after depolarization. And if it's right after, it's delayed after depolarization. So triggered activity. As I mentioned before, though, the main way is just reentry circuits. Now, you can have these on a global level, where it goes from the atria to the ventricles and then back to the atria, or you can have it on a local level, as we will see in the node, the AV node. We'll talk about both of these in more detail. So just a reminder that we start at the SA node, we go to the AV, we go to the bundle of His, and then we go to the Purkinje's. This is not a full loop. We have all of these reentry circuits, which are loops, and to understand them, we have to remember that action potentials can typically go both ways. So we're so used to the MCAT and pre-med where you initiate an action potential at the axon hillock and it just slowly moves in this particular direction. I guess technically it moves where we have the nodes of Ranvier and the sodium comes in and diffuses over, and then another action potential. So we typically just see the action potential generate, be carried in one particular direction. But if you had a nerve and you just electrically, artificially, externally stimulated right here, and there was no action potential, you would technically get an action potential that moves in both directions. So again, this isn't a normal physiological state, but you could artificially induce an action potential to move in both directions. The only reason it doesn't normally do this is that we have repolarization, which is part of the hyperpolarization. We have a refractory period, so it won't go in both directions. So it just moves in one direction. So long story short, things can go in both directions. They don't normally, but if they do, it leads to a pathology. So how can, in a cardiac myocyte or a nodal cell, how can we have things moving in both directions? So I mentioned earlier that you could have an MI or ischemia, which could lead to this non-conducting scar tissue over here. There's other ways that you might have these non-conducting regions, but this is the main one that I'm aware of. And so we might have an action potential moving down here, and some of it goes this way, and some of it goes this way, and some of them go this way, some of them go this way. And when they do, they're going to collide and cancel. And then some of them will go that way, some of them will go that way, and this is probably leading to the ventricles. It's probably coming from the atria. And a reentry circuit is somehow this gets into this eternal loop where it just continually goes around and around and around and around. This is just a nice picture showing that the island of non-conducting in the center is often due to a heart attack, and it can lead to a reentrant loop. Very important for this is, you guys are probably so sick of me saying this, but I'm going to say it again. Hyperkalemia and hypoxia will lead to slower phase 0 and larger phase 3 slopes. This leads to a shorter refractory period. On the other hand, if something has a fast phase 0, this would be like a wild type, it's going to have a slower, longer refractory period. So fast conduction leads to long refractory period, and slow conduction leads to short refractory period. And so let's imagine that all of these are cardiac myocytes, and again, fast with long refractory and short with short refractory with slow. And let's see how this moves. Boom. Notice that one goes really quick. And this is all in refractory, done. Let's watch that again. You'll notice that the fast one stays in refractory longer than the slow one. Refractory, out of refractory, still in refractory, now it's out. So that is very important. And again, that all has to do with this. And again, when you think about hypoxia would be induced during an MI or something like that. So it's a nice little connection there. So a normal thing, we have this infarcted tissue. I have an impulse coming down. Some of it goes this way, some of it goes this way. Let's say that the blue one is slow with a fast refractory period. The fast one is going to get through first, and then it's going to loop around, and then it's going to cancel on this. This is, again, the normal state of affairs. So that's great. I just have one signal in, and I have one signal out. Hurrah. And this is going to the ventricles and going to cause them to contract in a nice coordinated fashion. But what if, quickly, maybe like 1 second after, so I guess if we have these impulses every second, then this would be a heart rate of 60 beats per minute. So if shortly thereafter, I have another action potential come down the road, maybe remember that the red is a slow refractory period. So maybe it tries to go in this direction, but it can't because the red area is in refractory. So instead, it just goes the only way it can, which is the blue. Why is the blue not in refractory? Because the blue is a very fast refractory recovery. And so then it's moving along, and we can continue the picture here. It's moving along, and you know what? Now blue wins. Blue is now going to win the day, moves down, it activates the ventricles. But as it has moved down, the red has just ended its refractory period. So can now actually, and it's unfortunate that my color is red, so ignore that. This is just pretend this is blue. It now can just continue in a little circle, as we see in this picture over here. And now it's in this eternal loop, which it will never exit. And it will send some signals this way and some signals this way. And again, this will just initiate a ventricular contraction. And this, every second when the newer action potential comes in, it will crash into it and it'll stop it. It'll reset everything. And this is actually pretty fast that things can move around the loop. So we said it was 1 second, which is 60 beats per minute. Now imagine that you can go around this circle once every quarter of a second, every 0.25 seconds, which means we have 240 beats per minute. This is a re-entry circuit. This is how we get atrial tachycardia and ventricular tachycardia. So these things can be local on a small scale, like whether in the atria or the ventricles, or they can be global, which is where we're going to go from the atria to the ventricles. So we're going all the way around. Now, how does this happen? The only way that I think you'll really encounter is something called the bundle of Kent, which is sometimes called an accessory pathway. And this is, so bundle of Kent is the accessory pathway. And the disease, the pathology where the issue is Wolff-Parkinson-White. So those three things are together: bundle of Kent, Wolff-Parkinson-White, and accessory pathway. So rather than the SA node traveling straight to the AV node, some of it goes through this alternative route. And remember that the AV node is particularly slow, so it's likely to get to the ventricles more quickly. Now, it might also go through the AV node, but it's just quicker through the bundle of Kent, and it's going to excite the ventricles a little bit prematurely. And we'll talk more about this later. There's a lot going on with that, but that's just the idea of a local versus global. So, here's our heart. Here is our atrias, and here are our ventricles. If you have a tachycardia which originates from above this line in the atria, that is a supraventricular tachycardia. If it's below this, it is a ventricular tachycardia. We're typically going to have a normal or narrow, let's just think of it as normal QRS complex, and the SA node is, for the most part, still there. So even if I have a really large, typically when things start in the atria, and this is the SA node, this should say the AV node. The AV node is there to try to prevent and delay signals that are coming to it too quickly from the atria to being passed on to the ventricles. And we'll see how this works, when this fails, et cetera. The types of supraventricular tachycardia is atrial flutter, atrial fibrillation, and avian RT, which is atrioventricular nodal reentry tachycardia. We then have the ventricular tachycardias where there is no AV node defense. Again, SA is where they originate, AV node is where there's the delay. And widened QRS complexes, this could lead to VFib. VFib and VTAC both are the major forms of cardiac arrest, also known as sudden cardiac death. So supra, above, ventricular, ventricles, tachycardia, fast heart rate. If something's paroxysmal, it just means that it's every now and then. It's not like constant. And usually this just means it's in an earlier form. It might progress to a chronic, long-lasting, permanent tachycardia. So again, these are our four types. Far and away, the most common is the AV and RT. and then the Wolff-Parkinson-White AVRT versus AVNRT are is the next common, and then atrial flutter and atrial fibrillation are a little bit less common. And they might still be common in terrible pathology, but in terms of the tachycardia, it might be a little bit less common than the RTs, the reentry tachycardias. So atrial fibrillation is when this is what we want to happen. We want things to go at the SA node and then move nicely through the AV node and then move down here in a coordinated fashion. Just looks beautiful. And this one is just chaos. We just have all signals in some completely quivering, non-synchronized manner. And if it's non-synchronized, that means I'm going to have cardiac myocytes contracting at different times and not in a coordinated fashion. And this leads to regular heartbeats. But most importantly, this means that I don't have a P wave. I don't have an atrial kick. So an ectopic foci is just some pacemaker cell which initiates the impulse more quickly than the SA node. Randomly, this is often the pulmonary veins. The cells there can initiate their own diastolic depolarization current. Reentry circuits can also sort of serve as the focal point, the thing originating. I suppose they're more just maintaining an action potential and just passing around in this forever eternal loop. But ectopic foci, reentry circuits, and both of them are going to be caused by just the weathering of time, coronary artery disease, alcohol especially, which is called holiday heart syndrome, things like cocaine, antiarrhythmics, etc. Notice we have these nice little P waves, that is the atria contracting together as a unit. And then I have these fibrillations, which are just random chaos. And notice we get this just silly little thing, which is just this non-coordinated. Because everything to contract at the same time, we get a nice, clean electrical signal that the current is moving in one clean direction. But you get something like this, where it's just all contracting at different times. So if we look at this, we could have a reentry circuit, the pulmonary veins somehow beating out the SA node. And you probably have lots of them. So atrial flutter is very similar. The main difference is that we typically just have one dominant source of conduction. So rather than lots of many different competing things, we just have one. So something is still beating out the SA node, but it's just one. So there's a little bit more uniformity. So we still have the AV node, though, to act like defense for the ventricles. So effectively, so here's my SA node, and the point is that the reentry circuit is winning out. So let's see what happens. It might move really quickly. 1, 2, 3, 4, and then it gets passed through the ventricle. So that is the AV node playing defense when I say that. That's what I mean. It has a long refractory period and a slow conduction velocity. And as a consequence, it might be 4 signals from the atria from this reentry circuit, again shown here, that is knocking at the door saying, hey, can you let us in? Can you let us in? We want to get into the ventricles. But the AV node, because of the refractory period, can only do 1 in 4 or 1 in 2 or 1 in 3. It'll usually be a clean ratio, and the details there are just going to depend on the types of damage, the types of, it just depends on how screwed up the heart is. And you can kind of see here, we have a little bit more 1, 2, 3, 4. This would be a 4-to-1 block. And I guess that's what we saw in our picture. 1, 2, 3, 4, boom. It could be 2-to-1, it could be 3-to-1. But so if I have a 300 beats per minute from the atria because of this conduction loop, it might be 150 beats per minute for the ventricles. AVRT, so atrioventricular reentry tachycardia. So again, this is Wolff-Parkinson-White, the bundle of Kent, also known as the accessory pathway, and it's second most common supraventricular tachycardia. So the idea is usually we go from SA to AV, but there is this alternative route, and this alternative route is likely faster because the AV node is notoriously slow. That's sort of its job. Also, 0.1% of people have Wolff-Parkinson-White, which is actually relatively common. So this could be bad for a couple of reasons. One is that, like we just saw, we have this defense over here. Bum, 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 bum. So 4 and 1. So we had a really, really large, you could imagine if it was 4-to-1, you could imagine it's 300 beats per minute. and then it's only 75 beats per minute when we look at the ventricles because of the AV node defense. But in a situation like this, if I somehow had an atrial tachycardia for whatever reason, maybe I develop a reentry circuit on a local scale in the atria, it's going to pass through the accessory pathway, and it's going to initiate the ventricles to also beat at 300 beats per minute. There is no delay. There is no refractory period of the AV node to save me. So that's one reason that it's bad and can lead to a tachycardia. Second reason is that it might just so this is Wolff-Parkinson-White without the reentry on a global scale. This would be the reentry on a global scale. So rather than originating here, it might just say, you know what, it's much easier and more fun just to initiate, just to continue moving in this direction forever and ever and ever and ever. So this is orthodromic when the impulse moves through in an anterograde fashion through the AV node. But it could also be an antidromic, which is really just the same thing. It's just now it's moving in the other direction. But both of these are global reentry circuits. Global makes sense. It's the whole heart. And it is AVRT because it's atrium in the ventricles, and it's reentry. So all of this, the names actually are kind of perfect. AVNRT, N is for nodal, and AV is for the AV node, basically. And so just people getting older, genetics, females randomly, this disproportionately affects them. There might be many different ways to get through the AV node, or we have ischemia, like we said, which creates an island of non-conduction, et cetera. But because it's at the AV node, it's kind of like past the gatekeeper to some extent. So we pretty much don't have the gatekeeper phenomena anymore, which means it's a 1-to-1 ratio. So for every time the atria contract, the ventricles also contract. And we kind of see, so this is maybe a normal heartbeat. This is P, this is our QRS, and then this is our T-wave repolarization. But here I'm going to see a QRS, and then a P, and then a QRS, and then a P, and then a QRS, and then a P, and a QRS, and a P. Actually, you know, I take that back. I don't even think this is a P. I think this is a T-wave. But the idea is it's very quick succession, and it's 1-to-1, and it's 1-to-1, and it's it is a regular rhythm, but it's much faster. Also, just a note I meant to make earlier. We see the repolarization in the T wave of the ventricles. Where's the repolarization of the atria? It's technically inside of the QRS complex, but because it's so small compared to the ventricular contraction and conduction signal, that it kind of gets lost and obscured by the larger QRS amplitude. Okay, ventricular tachycardia. So now we're south of the border. Similar to atrial flutter. Atrial flutters, we have one ectopic foci or one dominant reentry local loop that just generates a current. But it gets blocked at the AV nodes. That's why we have the 4-to-1, 3-to-1, 2-to-1, et cetera. But here, it's already in the ventricles. So it's already past the AV node defense. So the ventricles can contract to their heart's desire. So it's still coordinated. And again, we have coordinated ectopic foci or local reentry circuits, which are what's going to be generating this. VTAC can evolve to, we should say, VFib. Can also evolve to cardiac arrest and asystole and things like that. So this is the SA node beating out. Let's watch that again. This is the SA node winning. Notice that the SA node beats every 1 second. The AV node beats every 2 seconds. But if the SA node signal gets to the AV node while the AV node is still in process of doing the diastolic depolarization, it resets everything. And that's exactly what we see. It never gets really past here. But now we're going to cross this out and now see what happens. Boom. Now it does it on its own, but it goes much slower at the ventricles. Now, if it gets irritated, it can go much more quickly. So earlier I said the AV node, but it could also be the Purkinje fibers. So they're now calling the shots, the ventricles, if they become faster. So you could have that the SA node or AV node are damaged and the Purkinje fibers take over, but more likely they get irritated. You have a hypokalemia. You've got something wrong with them. Someone's taking too much alcohol. There's too much cocaine. And the ventricle, it affects. Remember, they have their own little tiny phase 4, but it's very sensitive. And so the slope increases dramatically. and it becomes 0.5 seconds, and it now becomes the dominant. So that is probably the main mechanism by which we generate a ventricular tachycardia. Ventricular fibrillation is just like atrial fibrillation. So we have all of these ectopic foci, we have all of these reentry circuits, but there's just not enough coordination. There's not one dominant one. So we've just got signals coming all over the place, and so we're not going to have a coordinated, regulated team effort contraction, which is necessary to get the blood out. It's just going to be all chaos, this quivering effect, which is what fibrillation means, and can evolve from VTAC, can again lead to cardiac arrest.